have the pleasure of introducing Dr. Samuel Braude. He is an assistant professor of neurological surgery at the University of Washington School of Medicine. He's a neurosurgeon at UW Medical Center, Harborview, and Seattle Children's, director of the hydrocephalus, co-director of the tone management program at Seattle Children's, and director of the Synapse Program for Innovation and Commercialization in Neurological Surgery. He, I think as you can gather now, specializes in pediatric neurosurgery, especially, guess, children with hydrocephalus. That was my segue, right, into him today. And in brain and spinal cord tumors, spina bifida, and Chiari malformations. He's developed a number of neurosurgical technologies to improve the treatment of hydrocephalus that I'm really excited to hear about and have him present to you. He also started 2 local companies to commercialize the technology, Aqueduct Neurosciences and EcoGuide Medical. And he received his MD PhD from the Medical Scientist Training Program at the University of Florida in Gainesville. Did a 7-year neurosurgery residency in Utah and completed his pediatric neurosurgery fellowship training at UW and Seattle Children's, and also completed a research fellowship focusing on functional magnetic resonance imaging.
Well, thank you, and good evening to everybody. It's quite an honor to be able to come and talk to you, and I've brought one of my favorite families that I treat. I think as a physician, the thing that sometimes we forget is the human side of what we do. We get wrapped up as we're learning the science and the technology, and really the reason we become doctors is to take care of patients, take care of families, and for us who take care of children, I think we're extraordinarily privileged to be able to interact and hopefully improve their life. And I wanted to start out today, I'm going to be talking about hydrocephalus, which to me, you think about neurosurgery, it encompasses brain tumors, aneurysms, complex spine problems. But if you talk to a neurosurgeon, one of the most challenging things is actually dealing with hydrocephalus. It's not that it's difficult to get the fluid from one spot in the body to another, and we'll talk about that. It's really difficult to make those systems work well and to not have to have repeated surgeries over and over again. And I thought I'd start out tonight by bringing Justice and his family up to talk to you guys for a few minutes so that you kind of understand the context that I'm going to be bringing the rest of the science and sort of technology piece to my lecture tonight. So I'd like to bring Justice and his family up to talk for just a couple minutes so you kind of understand in context what they've dealt with over the last several years. So do you guys mind introducing yourself real quick? This is obviously Justice, who's one of the most adorable kids you will ever meet.
Say hi.
Hi.
This is Justice, and he's 4. I'm Sarah, and I'm his mom. And I get the privilege of staying at home with him.
Hi, my name's Andy, and I'm an active duty soldier down at Fort Lewis, and just wanted to thank you all for having us here tonight, and praise God that we were stationed at Fort Lewis so close to the amazing medical staff at Seattle Children's.
So what I really wanted to get everybody to understand was sort of really the path that you guys and the journey you've taken since you found out that Justice had hydrocephalus. Do you mind talking just a little bit about sort of the day you heard the diagnosis hydrocephalus, and did you understand what that meant at all at that time?
No, in fact, I had never known anyone that was a preemie, and I'd never really heard of hydrocephalus. Justice was born 10 weeks premature, and he was just a little under 2 weeks old when they told us that he has hydrocephalus and that he would be needing brain surgery the following day. And that was his first brain surgery.
And so he had the procedure, and we'll talk about this in a few minutes. The procedures, as surgery goes, is usually pretty quick. It's about an hour all told, give or take. So it seems like a very straightforward thing, but things for him became problematic after the surgery. Do you want to talk a little bit about what you guys experienced?
The first surgery was to place a temporary shunt because he wasn't big enough. He was he was a preemie, so he was still little. And during the second surgery, we ended up finding out that he got a spinal fluid infection. So after that, became a whole host of issues that occurred after that, which resulted in several other surgeries to follow to correct the infection and solve that problem.
So when I first met you guys, you had been treated at an outside hospital and had some of these things done. They're fairly typical procedures that are done at multiple hospitals around the country. They're specialists typically at those hospitals, pediatric neurosurgeons or sometimes adult neurosurgeons who will treat these problems. And infection, as I'll talk about, is a very big part of taking care of kids with hydrocephalus. The rates of infection in a setting of putting in a new shunt are anywhere between 5 and 15% at really good places. And so the infection risk is really high. And so when I met you guys, you had come in and he, at that point, had a very significant infection. You were in the neonatal intensive care unit for how long was it? Like,
we were up at Seattle Children's for a couple months in the hospital with him. It became home to us because of how severe his infection was and how long it took to clear up that infection. And so we ended up having to be there for a really long time, and it took a good portion of our lives.
So together we went through quite a lot, many surgeries to treat the infection, temporary drains that are in place, finally got to the point of putting in a shunt, and then even once the shunt went in, there were still shunt failures that came after that, and I'll talk about that. For life-saving technology, 30% of shunts fail within the first year, and we'll kind of talk about why that is. And so someone of his age, by the time they're 18, is going to end up having 6 or 8 surgeries on average, okay, to replace the shunt or fix it. And so you guys unfortunately experienced that probably more so than a lot of families. And he's had how many operations now?
Yeah, we've had to kiss him goodbye to the operating room 13 times, which is a lot for a parent to handle. And I always say it was Christ that got me through, because it's the heartache that you feel as a parent watching your child suffer over and over and over again is just absolutely more than anyone can handle themselves. So it's been a really long journey for us.
So he went through a ton of surgeries. Unfortunately, he's doing really great, and I get a chance to see you guys regularly back in clinic, which is always a pleasure for me, because he's just crazy adorable. One of the things with shunts is we don't know. I told you they fail frequently, so we don't know as clinicians when they're going to fail. And one of the big problems that families face is when they have a kid with a shunt, they don't know when the thing's going to not work. And so that puts, this incredible burden on families. I have families who no longer travel. They won't go to Hawaii. They won't go to foreign countries because they're worried if they're outside of medical care and the shunt fails that, tragedy could occur. And so do you want to talk just very briefly about the psychological aspect of that?
Yeah, it's kind of difficult to put into words the amount of stress and the burden that it puts on my shoulders. But at 4 years old, most moms don't typically have a baby monitor in their children's rooms anymore, and we do, because unfortunately we've actually experienced a shunt. Well, what ended up happening was he ended up having a 40-minute long seizure because of all the pressure that was building in his head, and it was during when he was sleeping, and so I wasn't aware of it. So from that moment on, he's had a baby monitor on him at all times. I worry every time he says he has a headache, if he's not feeling well, if he throws up, it's a trip to the emergency room. Every day, you live in fear of this thing failing on you. And I don't think most people realize that shunts have the worst success rate out of any medically implanted device. And so we live with that every single day.
So the last thing I want to ask you guys is, what do you hope for Justice in terms of sort of medicine and technology and all that stuff? He's a really young guy, and there's a lot of cool stuff hopefully going to happen in hydrocephalus that will hopefully affect him for the better. What kind of things are you hoping to say?
Well, obviously we're hoping for a cure, and I think just some tangible things now are just awareness, dollars to spend on research. and just more advances in technology. Shunts have been around for a really long time without any advances, and we're really blessed to know Dr. Browd, and I think he's going to be talking about it later, but some of the things that he's working on to kind of improve shunts and make them more reliable. And so, you know, that's our dream. I dream of the day that I don't have to have a baby monitor on him or live in fear, and that there'll be more advances and for kids like Justice.
Well, I can't thank you guys enough for coming and for Justice staying up past his bedtime tonight. We'll give him a big round of applause.
Bye. It is done.
Thank you.
Thanks, guys. So this is why my life's great. I get to take care of, you know, gorgeous kids like him and wonderful families, and it makes the many, many years of school well worth it. I'm going to go through now and kind of step into sort of the science and technology of what I do on a day-to-day basis as a neurosurgeon. So I'm going to briefly go through hydrocephalus and explain it so you kind of get the context of the disease and then what we do to treat it. So it's actually extraordinarily common. 1 in 500 to 1,000 births, the kids have hydrocephalus. And if we're talking about adults, which is not part of this conversation tonight, but we think 1 in 10 patients who have Alzheimer's type symptoms actually have normal pressure hydrocephalus, which is an adult version of this problem. In kids, it's associated with premature birth, congenital anomalies, trauma, tumors, and infection. And it's the -- reason for brain surgery in kids. If you look at this picture here, these are the fluid spaces that you saw earlier during the last lecture. The brain's compressed, so this obviously isn't a good thing for the brain to be smushed up against the skull. Interventricular hemorrhage is when you have a premature baby and the areas around the periphery of the ventricle are fragile and can bleed, and you get blood in the spinal fluid space. And for reasons we don't understand, in a high majority of kids, they stop reabsorbing spinal fluid properly. You keep making it, but you don't reabsorb it. And so it can be a serious, IVH is a serious complication of premature birth because it can lead to hydrocephalus. It's interesting, even though it's a common problem, there's not a consensus on management. The timing of shunting, the weight of the baby when you shunt, a lot of these things are still in flux, surprisingly. While the incidence is decreased, there's clearly a direct correlation between increasing prematurity and the severity of interventricular hemorrhage. And the younger the baby, the more likely they are to have IVH, and the severity of the IVH can be higher. These are some pathology slides. If you're in medical school, you'll see tons and tons of this. And again, the germinal matrix is sort of part of the lining of the ventricle. The subependymal zone is one of the areas we think is problematic, and one of the reasons they have hemorrhages. It's very metabolically active. There's a rich blood supply. We think there may be problems with autoregulation. So the brain normally can control its blood pressure fairly tightly, and if you have altered regulation, you can have a hemorrhage. And there's a variety of risk factors that are listed up here: young gestational age, low birth weight, acute pneumonitis, other things listed here. So there's a variety of associated factors that can lead to it. There's a variety of causes of hydrocephalus. So prematurity in IVH is one. Severe brain trauma is another. So 30% of severe brain trauma patients end up with hydrocephalus. Gabby Giffords, everybody's heard her story. She ended up with that bad head injury getting a shunt. So she actually has hydrocephalus. Congenital anomalies, spina bifida, a very high percentage of patients who present with spina bifida have hydrocephalus. It's upwards of 80%. Meningitis, if you get a bad meningitis, those mechanisms of reabsorb spinal fluid can shut down and you get hydrocephalus. Brain tumors, I treat a lot of kids with brain tumors. One of the presenting symptoms is the tumors blocking how spinal fluid gets out of the ventricle. It dilates, they get headaches, other symptoms, and often that's the first reason they're presenting. It's not because of the tumors, it's because of the hydrocephalus. And there's other causes as well. These pictures demonstrate patients we've treated Up here, this is a patient who had a bad trauma. They went to Harborview. They did a decompressive craniectomy. They took half the skull off to allow the brain to swell. In that setting, the patients developed hydrocephalus, and they're pushing the fluid outside the brain. This is all fluid. This patient was shunted 2 days ago. This is a patient with a myelomeningocele and open spinal cord defect. And here's a patient with a posterior fossa tumor that's in the cerebellum of the brain on the floor of the brainstem. And we take these tumors out, and about 50% of the kids end up having hydrocephalus and need a shunt placed. Prior to about 1950, this was a horrendous problem. There was no way to treat these kids. And so the heads just got bigger and bigger. These pictures are awful. And eventually, the soft spot on the head would rupture. They get meningitis and die. Okay? So the fatality rate was extraordinarily high. I think 60% is what's published. I can't imagine that it's that low, to be honest. So what do we do nowadays? So there's a couple temporary treatment options. In Justice's case, he was too small to get a shunt to start with, and I'll explain what a shunt is in a minute. You have to be about 2 kilograms to get the implanted tubing. So how do we temporize? So historically, we would just stick a needle through the soft spot and drain off spinal fluid. And we would take 10 cc's or milliliters per kilogram, and we would just watch the head circumference. If it got too big, we'd tap it. Now, a lot of people have shown that it doesn't really decrease the need for a shunt. It doesn't really help a lot in terms of disability, reducing it, death rate, things like that. And we know that it actually, doing that procedure now, has a very high infection rate because you're multiply accessing into the brain and spinal fluid. A lot of times you get erosion of the brain by multiply puncturing it, and you can actually cause aneurysms. So most of us don't do that procedure except in emergency now. One thing we do that was shown on the back, the last slide, is lumbar puncture. So we'll occasionally do those serially to drain off spinal fluid. Or as is shown here, we'll put in what's called an extraventricular drain. So it's a catheter that goes into the spinal fluid, hooks to a bag, and we drain that for a period of time. That also has issues. The infection rate's reasonably high. You can over-drain or under-drain them based on if they're moving, then the way the bag is set up, the fluid just free flows out, so you have to level it each time they move to keep it flowing at a constant rate. The catheters can migrate, and so the baby's brain is very mushy, and so you put this fairly stiff catheter, and over time, if it's left in place, it can actually just like through butter move through the brain. It's not very nice. Wound healing's a problem. These premature babies, their skin is super thin. It's like tissue paper. And so sewing that up and keeping that healthy with a tube coming out is not that easy. And the majority of the kids who get a temporary drain like this end up needing to be shunted. What we more commonly do now is we put in what's called a subgaleal reservoir. So it's part of a shunt. It's a tube that goes into the brain, into the spinal fluid, and then there's a little port that the spinal fluid can come out of and collect underneath the scalp. And it's able to be reabsorbed somewhat, and it basically bridges us to the point that we can put in a proper shunt when the kids are big enough. So this is more physiologic. It's a little less invasive. You go to the OR, have a short procedure, and then go back to the neonatal intensive care unit of the floor. The infection rate's a bit lower with this, and by hybrid subgaleal shunt, I mean that if the fluid for some reason isn't pooling well under the scalp, we can actually take a needle and tap into the plastic reservoir versus putting a needle into the brain. So this is an advance, and this is sort of the state of the art at Children's, the way we take care of these kids. The picture on the lower left is a before and after. You can see the spinal fluid spaces have come down. The little bright dot is the part of the catheter that you're seeing in cross-section. These are three-dimensional reconstructions of a CAT scan showing the catheter going in and how the reservoir sits on the surface of the skull. Okay, and that big gap on the top picture on the right is really the soft spot in this child. It's markedly expanded from what you would see in a normal baby. This is what a subgaleal reservoir looks like. It's pretty basic stuff. There's a little tube and the reservoir, which is where we can stick the needle. There's a couple different varieties of this on the market, and we kind of pick what we like. So I'm going to move on. So now that the baby's big enough to be treated, there's a couple treatment options, and I'm going to talk about what's really sort of cutting edge and on the front of treatment right now in terms of avoiding getting a shunt, which is the tubing. So I'm going to talk about this first because this is a very exciting thing that we're really trying to push the envelope on and see if more kids are going to be candidates for this. So the procedure is called an endoscopic third ventriculostomy that we abbreviate at ETV. And the idea here is that in a lot of kids, if you create another path through the brain, the spinal fluid can circulate out and get reabsorbed. And so the area that we do that is the bottom of the third ventricle, which is right here in this cross section. So this is a model where we cut straight down the center of the brain. The brain stem is right here. There's a huge artery that runs up to feed the brainstem called the basilar artery that lives right here, and then we're poking a hole through the bottom of the brain right in this location. And by doing that, the idea is that the spinal fluid that's stuck up in the ventricle system of the brain can flow through, get to the outside, and properly get reabsorbed. This is done with an endoscope, so we're making a small incision, small hole to get in, and then we're using the camera to guide what we're doing. The anatomy here is spectacular. So what you're looking at is we've gone through the cortex of the brain into the ventricle, which is shown in the schematic here. This is the ventricle system in the middle of the brain. What you're looking at is the foramen of Monro. This is choroid plexus. This makes spinal fluid. We pass the camera through the foramen of Monro to go into the third ventricle. So lateral ventricles are up top. They come together into the third ventricle. What we're looking at in this picture is the floor of the third ventricle. The brainstem is here. These are called mammillary bodies, are part of the brainstem. The basilar artery, which comes out the vertebral arteries of the neck. So there's 4 major arteries feeding the brain, 2 vertebrals that turn into the basilar. The basilar terminates in this location right in front of the brainstem. The pituitary gland's here, optic chiasm is in this vicinity, and what we do is we place a hole right here. So not a lot of room for error. And the major risk of this procedure is perforating the basilar artery, which typically is a fatality if that happens. Fortunately, the risk of that is well below 1%, but it's not 0 doing it in this location. Again, the anatomy is right here where we want to put the hole. The way we do this is down the endoscope, we place a very small balloon that we can poke a hole in the floor and then serially dilate the hole up. And so this is an example of the balloon being blown up on the left. On the right is the hole that's made after that's done. And typically we can drive the endoscope through that hole and look at the basilar artery in front. So we're actually like right in front of the brainstem. It's the coolest thing ever. So I would be remiss without talking about Dr. Worf, who's a good friend of ours. He's at Boston Children's Hospital. And Dr. Worf went to Uganda for a number of years. And hydrocephalus is a horrendous situation in Africa because they can't afford shunts. If it gets infected, you die, essentially. There's not, Justice's situation where you're going to come into the hospital and have 20 operations. So you just die if something bad like this happens in most settings. So Dr. Worf went there, and he knew about the ETV procedure. And the failure rate with ETV, especially in young kids, can be quite high, 50% or higher. That's why still the majority of kids will get a shunt, which we'll talk about. But he brought back an idea that was really started back in the 30s with some of the founders in neurosurgery of cauterizing the choroid plexus. So the structure that makes spinal fluid, if you cauterize that, can you reduce spinal fluid production enough that between the ETV and cauterizing it, you get them by so they don't need anything done. And so he really took this on and has done, I think, several thousand of these operations in Africa. He's come back now and he's on staff at Boston Children's Hospital. And we've started to do this procedure at Children's now as well and have had good results with it. And so we're optimistic. I think data is still out, and it's certainly not going to replace the shunt for every child, but I think that in the properly selected patient, it's a great procedure. And it's done a little differently. We use this curved endoscope. So the first time I was doing it, I felt like I was doing a colonoscopy. But it's a little different than the way we normally do endoscopy. But after a bit of practice, it's pretty straightforward. So again, we're pretty optimistic about that. And I definitely want to call out Dr. Worf, who's been a great advocate for patients with hydrocephalus. When you do an ETV and you follow the patient, typically the ventricles will get a bit smaller, but they're not going to shrink up. to normal size typically. So these ventricles on the right side in this patient are still fairly prominent, but that's okay as long as the pressure is taken off. Long-term cognitive outcome for this has never been studied properly. So we don't know if this procedure is better or worse than standard shunting. It's just one of the gaps in the knowledge in hydrocephalus. Very important gap that some of us are starting to take on. A good friend of ours, Ab Kulkarni, who's at Toronto Children's, came up with an ETV success score so we can counsel the families fairly well in terms of what we think the likelihood of success with an ETV is. And it's based on the age, the etiology of why they have hydrocephalus and whether or not they've had a shunt before. We can kind of add up this score, and this has been validated in a few different papers and shown to be quite accurate. So we can make a pretty good assessment for folks whether the procedure is going to work. So I'm going to switch gears and talk about the VP shunt, so ventricular peritoneal shunt. This was the device that was invented in the 50s. There's, as Sarah was just telling you, there really hasn't been a ton of innovation in hydrocephalus, which we're hoping to change. Since the 50s, it's basically been a tube with a valve that drains spinal fluid from the brain to another body cavity. So we can put it in the abdomen, the lining of the lung. We can put it in a vein that goes to the heart and drip it into the heart. You can put it in the gallbladder, and people used to put it in the bladder. So we almost put all of them into the peritoneal cavity in the abdomen if we can do it. So again, it's the most common pediatric brain surgery. 70,000, 69,000 discharges per year in the US, 36,000 initial shunt placements, 14,000 revisions, and I'll talk about that in a minute. The cost of hydrocephalus is, actually this number is probably low. It's between $2.5 and $3 billion a year in the United States. So that's surgeries, hospital care, ER visits, all that stuff. Counts for about 3 to 4% of all pediatric hospital charges. So again, the shunt's a mainstay of therapy. The complication rates are really high. And I consider myself one of the most knowledgeable. I think I'm one of the best in the country at doing this. And no matter who's doing it, you get these complication rates. So I mentioned earlier about 6.8 shunt revisions if you get a shunt at birth by the time you're 18. Crazy. 30% of them fail within the first year. 90% fail within 10 years of implantation. So it's the minority of kids that I'm seeing in clinic who got it when they were born, and then they're like in their teens and they've never had something done. Infection rate is ridiculously high. So published numbers are 5 to 15%. If it gets infected, you got to go to the OR, take the whole thing out, put in an externalized tube like I was showing you before, treat with antibiotics for 2 weeks, then reoperate to put the shunt back in, and then the incidence of shunt infection on that second surgery is actually even higher than these numbers. So if it's 5%, it jumps a couple percent beyond that. So it's just a bad situation. So here's an example of shunts. So new shunt insertion. Again, I showed you this picture before. Ventricles are big, you put in a shunt, the ventricles come down. This is a typical way we're evaluating a shunt in the ER is to get a shunt series and a CAT scan. So if Justice's mom says, oh, Justice threw up a couple times, I'm really worried. She doesn't know if it's the flu or he's got a shunt malfunction, right? So it comes to the ER, gets a CAT scan. So if kids in the practice had 90 CAT scans, that's not good. They get a X-ray to make sure the shunt's in continuity, the tubing's not broken. And then we try and figure out whether they need to go to the operating room. So these are the studies that we typically get. So the shunt series is a plain X-ray. You can see the catheter going in the brain. There's a little connector called a Rickham reservoir. This is the valve that regulates the flow of fluid, and then tubing that goes down to the abdomen. Common question I get is, well, you got a little baby. How do you account for the fact that they're going to grow to 6 feet tall? We put a ton of tubing in their belly, so you can see it all coiled up. A lot of the pediatricians are horrified when they see their kids come back to their practice and go, what are you doing, stuffing them full of all that tubing? But they do fine, and then they grow, and hopefully a shunt doesn't fail, and then the tubing grows with them. The picture on the bottom is a typical case of a kid. This is a kid who's been operated on multiple times. There's their CAT scan. At the bottom, you can see these old holes in their head from prior shunts. This is what the shunt looks like implanted. This is one type of valve. She came in almost comatose because the shunt failed. The ventricles expanded. There's a lot of complexity to hydrocephalus. The compliance or the squishiness of the brain changes for reasons we don't understand. And so some of the kids even though they manifest extraordinarily high pressures, their CAT scans don't always change. So a lot of times they'll come to the ER, somebody who's inexperienced in hydrocephalus will look at them and go, oh, well, your ventricles haven't changed size, and they'll say that they don't have a shunt malfunction. They'll go home only to return in extremis on death's doorstep, and we're rushing them to the ER. So the main reason I'm going in to operate in the middle of the night is to fix a shunt, okay? So we fix it, and then the ventricles come back down, and the ventricles in this kid are what we call slit-like. They're basically non-existent, and that's the tube in there. So how do you put these things in? So typically we're doing it based on anatomic landmarks, and I'll talk a bit about why there's better ways to do that in a second, but we do this for any catheter put into the brain. There's standard anatomic landmarks. So you go mid-pupillary line. The coronal suture is that little ridge you feel on your head. So we're about 1 centimeter in front of that. 3 centimeters off midline. Open up, burr hole, okay, hole through the bone. Open the dura, which is like a thin leather that covers the brain. Then you go perpendicular to the skull, 4 to 5 centimeters. Boom, you're in the spinal fluid, hopefully. Okay, so that's the freehand method. I'll show you the better way that we're doing it with some technology now. So this is a typical setup in the operating room, okay? Little baby, there's a full-on brain surgery, full anesthesia. You're laying there, they're positioned properly. We're shaving their hair, a lot of psychological issues with that, right? Your 14-year-old girl, you got to shun, your shunt fails. I'm going to cut half your hair off, then you got to go back to school a week later. Pretty horrible. We do big incisions here. Other places do small incisions. This is the drill we use called a perforator. The thing spins, and hopefully it stops when it goes through the other end of the bone, and that's how we make the burr holes. This is us assembling and connecting the shunt and then closing the incision up. One of the main things we try and do is stay extraordinarily sterile during the case. We don't want people walking in and out of the room. We don't want unnecessary things going on for fear of infecting the shunt. So what components are there to the shunt? How do you put it together? So we build ours from individual pieces. They make shunts that are pre-assembled for the majority of the parts. So there's a catheter that goes in the brain. You can buy them pre-cut. Sometimes we just use long catheters that we put in and then cut them to size. There's a variety of valves made by manufacturers, and then the tubing that goes to abdomen. So we got a whole carton of OR with all this stuff, and then I can pick and choose what I like. So how do these valves work? So they're called, the majority of them, differential pressure valves. So you get to a certain intracranial pressure with the fluid that allows the valve to pop off and start to flow. This is an example of what's called a programmable valve. So there's an artificial ruby bead that has a lever on it. Once you overcome the force that you set it at, the fluid goes around the bead and then through the valve and then out the tubing to the abdomen and gets reabsorbed. We use programmable valves. There's also non-programmable, meaning that they're sort of set within a fixed range. The advances I told you about, which were very few and far between in hydrocephalus, have been the advent of what's called an anti-siphon valve. So one of the early problems they noticed were patients would stand up and they just drain all the fluid out because it's like siphoning gas out of a gas tank because of gravity. And so they put anti-siphon valves to help with that. But if I was in the OR and I thought, okay, little baby, they have low ICPs, I want to put a low pressure valve, but for some reason they don't like that and I need a medium or high pressure, I got to go re-operate, re-expose them, all the risks of surgery. So big advent about 10 years ago is a programmable valve, which only means that using a magnetic device, you can alternate between different pressure settings. And I think I have an example here. So this is one proprietary valve that we use called a Strata. It's got 5 settings. And basically each setting runs through a particular range of pressure. So if I want a low pressure, I can set it at one number. If I want a high pressure, I can set it at another number. And then it shows kind of the way the performance changes with the patient upright or laying down. So accuracy of placement. So there's not a lot of studies that look at this, but skilled neurosurgeons get the catheter into the exact right spot they want it only 60% of the time. So it's one of the main reasons probably that shunts fail is that the catheters are misplaced by the skilled person. So again, I told you got to be perpendicular. If their anatomy is a little funky, a lot of kids have weird head shapes that are coming in with hydrocephalus, so kind of the textbook stuff may not always get you to the right location. So One of the major medical manufacturers, Medtronic, came out with this thing called Axiom. It's super cool technology. So basically, I can take an MRI or CAT scan, bring it into this computer system, and register the patient to the computer image. Those are little dots on the baby's head there on the bottom left. Then I can do basically GPS. I can pick my entry site and my target, and this thing gives me a heads-up display I like to think I'm a fighter pilot, and I zero in on it, and then I drop this thing down, and it's extraordinarily accurate. So I use this on every case. The downside, or the reason people don't use it, it's about an additional $800,000 disposable cost that goes into the cost of operating, okay? But to me, it's worth using that, but I am trying to get people excited about it. It's a big setup. This is the device in the top right here. The machine itself is about $500,000, and so it's a big expense, and that's why a lot of people don't use it. So why so many operations? I mentioned failure rates, 30% in 1 year, 40%. 2 years, between 90 and 98% within 10 years. Infection rates are very high. What are we doing to improve it? So I'm going to talk for the last couple minutes about this. So infection. We're part of a multi-center group called the HCRN, Hydrocephalus Clinical Research Network. So it's some premier children's hospitals around the country and also in Canada. And they came up with a standard protocol for how we're going to do shunts. Okay, it doesn't account for all 150 variables that you go through to put in a shunt, but we went through the literature, found what we think are key things. So just double gloving, properly scrubbing, not letting people come into the room while the surgery is going on. And we started testing this out, and we're really the first surgical group at Children's to do a standardization of a surgical procedure, and this is becoming a very hot topic. Partly because we found that if people standardize, the infection rate across all the groups got better. So across the different starting centers, it was about 8.5% infection rate, and it dropped to 5.7, which is highly significant. And it may be that people felt they were getting watched, so they did a better job, but even taking those factors into consideration, the infection rates improve. So there's something for standardization that allows you to then change the protocol to see if one factor is more important than another, and so we're currently doing some of those studies. Past years, our infection rate, even while it was low, it was still too high for anybody's comfort, okay? We want it to be zero. It's never gonna be zero, but we'd like to get there. But if you look in the last few years since we really implemented the protocol, which is around 2009, our rates have generally been coming down and down and down. And so we have one of the lowest infection rates currently in the country, which we're very proud about. Mechanical failure. So I told you that a bunch of the valves fail. So why does that happen? So 60% of failures are in the catheter that goes in the brain, 30% at the valve, 10% in the abdomen. So why do 60% happen at the catheter going in the brain? Because tissue grows into it. So when a patient comes in, half the time I can't pull the catheter out without cauterizing it because there's so much choroid plexus or brain tissue that's grown in to occlude the holes. And so this is an example of an explanted catheter. You can see the holes are really tiny, okay? And so it's easy for them to get clogged up. And there was no science back in the 50s that went into what the hole size was, the geometry. We still use the same thing. This is choroid that's grown into these holes, and once you get about 70–80% of them obstructed, then the amount of flow through the thing decreases. These are some studies we're doing, catheters implanted into rabbits, doing high-res 14 Tesla MRI to understand what happens with tissue ingrowth, and then some histology looking at that. We're using Axiom, as I mentioned, to try and accurately place the catheter, and we think that has some survival advantage, which you see here, between freehand placement and Axiom placement. The story is still out on that, but I'm a big advocate and believer in that. So I'm going to wrap up with sort of what's got me particularly excited in the last couple years. I had a very, I do this day in and day out, and it gets you thinking about what the problem is. And I kind of, I'm a pretty rational guy, and I go, this is just ridiculous, right? It's a life-saving device that fails 30% of the time in the first year. There hasn't been any improvements really made in technology since the 50s. Like, why is that? It's ridiculous. So was very fortunate to meet one of the bioengineering folks, Dr. Barry Lutz, and he's a microfluidics expert. And I said, Barry, he's about my age, he has 2 kids. I go, hey, I got this problem, I've got a couple ideas how to fix this. Come to the OR and see what's going on. So he came and was horrified, like anybody would be. It's sort of just the procedure when you have kids and the whole story around this. And so we started working together to basically throw out all the current technology and said, if you could take current technology and start from scratch, what would you do? And that's sort of the way we've been approaching it. And so through those efforts, we've developed a new shunt valve that we think is going to have great benefits on several levels. One is reduced failure rates, both at the valve and at the proximal catheter. So we have some technology we think will address that. It also hits on several important things. It's MRI compatible. So right now we do get MRIs on kids to avoid CAT scan radiation, but you have to reset the valve, and the valves are magnetic, and so we have valves that break because they're exposed to the magnetic field. So if you could have a totally MRI-safe valve, that's a huge thing. So we're incorporating that into the design. And then the other thing is understanding what's happening in that patient, both testing the valve, is it working, is it not working, having some auto-diagnostics in the device, because you make it electronic, you can do all that stuff, and also recording ICP or intracranial pressure. So Justice, as an example, if he's home and he throws up or his sibling's sick, his mom doesn't know whether it's the flu or whether he's got a shunt malfunction. And the idea with this device would be, we'll know his ICP is 8, that's fine. It's not 25, it's not 30, it's not going up and up and up. And so that peace of mind will totally revolutionize how we take care of patients, and I think revolutionize their lives in a better way. I think we're quite a ways away from curing hydrocephalus, but I think we're at the point in technology where we can improve the hardware that we use to treat the patients to make a dramatic effect on their life. So we're hoping with that we're going to be somewhere between 3 to 5 years out from getting this into a patient, and we have gotten about $1 million in funding, and that's part of the acknowledgments here to recognize those people who support that work. So my chairman, Dr. Ellenbogen, my partner, Jeff Ogeman, Dr. Lutz, who I mentioned to you, one family in town, Paul and Lori Gross, have been unbelievable advocates for hydrocephalus. The Hydrocephalus Association has a wonderful website. If you'd like to learn more about hydrocephalus, please go to their website. We have a hydrocephalus guild at Children's that supports a lot of the research that's going on. And then various agencies, the University Commercialization Center, Coulter Program, Life Science Discovery Fund, Washington Research Foundation, and we've also received NIH money. So it's a privilege to take care of these patients and interact with the families. It's why I get up every day. It brings great meaning to my life, and you met this wonderful family in Justice, and I'm a lucky guy to do what I do. So we're going to take questions, I guess. Thank you.
And I'm to remind everyone with questions to come up to the microphone.
I'm assuming that somebody with hydrocephalus has to live with a shunt for a lifetime. And you've mentioned that Justice's mother doesn't know, Justice doesn't know if he's got a shunt failure. As people mature, is there any way they can come to recognize the signs of shunt failure? I mean, just like you recognize the signs of, say, having to go to the bathroom or knowing you're going to throw up, for example. Is there any way you can experience shunt failure systems and say, oops, this thing is failing, I need to get to an ER fast? And if that happens, is the person up to doing it?
Yeah, no, that's a great question. There are definitely some patients who are able to say that their shunt isn't working right for them and come to presentation so we can work them up and figure it out. One of the things that's often very challenging, though, is one of the complications or issues that patients with shunts have is chronic headaches. So one of the main signs that we would use to tell that the shunt's not working may be something that they live with and deal with day in and day out. So if they have a 5 out of 10 headache that day, that may just be their headache that they deal with all the time versus a shunt malfunction, so it makes it much more challenging. But there's definitely patients who are able to be very in tune with themselves and come in appropriately early before they get into trouble and let us know that something's not right.
I actually had my fair share of experiences with myelomeningocele. So like when I saw that picture of that child, I was like, oh my gosh, that was me. But knowing that myelomeningocele could be associated with the hydrocephalus, what exactly are the levels of spina bifida, and what are these symptoms?
So I'm going to rephrase your question a little bit. So spina bifida can come in different forms. So some are open, some are skin covered, okay? Typically the ones that are skin covered are less likely to have hydrocephalus versus the one like that picture I showed where it's open to the air, okay? The ones that are open to the air, the risk of hydrocephalus in that setting is very high. And so again, I mentioned it can be as high as 80% of the kids who get their back closed end up developing hydrocephalus and need a shunt. So spina bifida itself is a fairly broad category, and some people apply it just to a defect in the bone in the back where everything else is normal. That's a different scenario than what I'm talking about with an open myelomeningocele that I showed here. Does that answer your question?
With the amazing early imagery for the neonates, I was wondering if there's anything that can be done for them pre-delivery, or how much damage occurs with all that pressure. I don't know, sorry, a broad question.
Yeah, no, that's actually a very insightful question. And again, sort of to complete the picture of sort of how much in the infancy treatment of hydrocephalus is, there isn't anything to be done in utero at the moment to treat hydrocephalus. There is a study for spina bifida where they're doing in utero closure of the myelomeningocele, and they showed that there was a reduction in the need for shunting in those kids. Not zero, but a significant reduction. That's probably a discussion for another day. It's called the MOMS trial, and it's a very fascinating study that has a lot of issues with it in terms of maternal fetal health and the risk of spontaneous abortions with doing that procedure. But I think that's where the future of some of this is going to go. Can we do something prenatally, during the time that the fetus is inside the mom to treat hydrocephalus? But currently we don't have technology to address that.
So there was a time, there are a number of things that we actually still do prenatally in placing shunts, but it's actually the last 10 years or so sort of fallen out of favor because we're realizing it doesn't work. So I'll give you an example. So my gray hair reflects the fact that I was in a time where the idea was that we would actually do in utero shunts, and we actually placed the shunts. And so if you can imagine, as Dr. Brown said, there's a soft spot right here, and we would actually put a shunt in there prenatally. And it very quickly, we realized that it wasn't working, it didn't make a difference. In part because either the shunt fell out, or actually the kid's moving around and it'll actually shake it out, or it'll actually go out and pull it out. So that's the funny piece. But the other piece also is that these shunts were kind of stiff, and some of them actually got embedded into the uterine muscle. And some of them actually worked themselves out through the uterine muscle, and so perforated the uterus. So I'm going to always come back to this piece of, you got to balance mom and baby, and what's the risk involved. So that fell out of favor. There's an international agreement among the, prenatal people in intervention that this no longer worked, and we were going to stop doing this. And we still place shunts every once in a while now in fetuses with what we call bladder obstruction. We do it less and less because, again, we are learning that it didn't make a difference in the long run for the same kinds of reasons. Either the shunts fell out, or they fell into the bladder and didn't make a difference, or they buried themselves into the uterine wall and caused permanent damage. And in the long run, we've learned that putting a shunt in a big obstructed bladder only was treating a symptom, but we really, at the end of the day, didn't treat the primary issue that was still going to be facing us when the baby was born. And so it is, however, my hope that we would do something with prenatal congenital hydrocephalus, because as you see from those images prenatally, that it's really hard to provide any sort of prognostic discussion with the family. And it's heartbreaking to find these ultrasounds at 20 weeks and not know what to do.
Yeah, no, I think my hope is the same, is that, as technology evolves, we'll figure out a way to deal with it. And whether it's the ETV CPC procedure or some variation on that theme, that may be something for the future, but to my knowledge, nobody's ever tried that in that setting.
A question for Dr. Cheng. I was wondering, you spoke a little about one of the categories of conditions you talked about. I think it may have been the first one, that the incidence was increasing, and you thought that it might have something to do with nutrition. And I was wondering if you could talk a little bit more about that, and also is there been any research or what has been found in terms of the difference in incidence among different demographic groups?
So that's a great question. The answer is that gastroschisis basically just baffles us. It just completely baffles us. We've recognized worldwide now, the literature basically says it's increasing, and we don't really understand it. Demographically, we see it much more common in young women, sort of the age range of sort of 16 to 21, 22, 23. We don't know why. I think that here in the state of Washington, we've definitely noticed clusters, and it seems to be, the cluster seems to be Eastern Washington. So, the intuition is that it's farm country. The CDC has come out and looked, and it continues to be sort of an ongoing surveillance and recognition that the incidence is increasing, and we don't understand it.
I have a question just in a normal pregnancy. What is the protocol for ultrasound? How often is it done? When is it done? Because it sure has changed.
Well, it depends on whether one is wearing an administrator's hat and I have to count the money at the end of the day. So there's really no standard of care, I guess is the way to say that. I would say that what's reasonable within critical developmental times of the pregnancy or the fetus. So the first trimester is a good time to have, an ultrasound. The ideal time is somewhere between 11 to 12 weeks. Fetus is big enough. We can definitely confirm viability, growth. We can see the heart. We can see the limbs. We can see the gastroschisis. If you have a good-looking ultrasound at 11, 12, 13 weeks, you can be pretty assured that, this is a pregnancy that you can definitely announce and have some assurance. So that's a good point to have an ultrasound. A second point is somewhere between 20 and 24 weeks. Fetus, the baby is big enough. You actually have a laundry list of anatomy, the ventricles, different other intracranial landmarks, four-chambered heart, the outflow tracts, kidneys, renal arteries, etc. So that again sets the stage that, okay, I'm halfway through my pregnancy, and up to this point, everything that should be there is there. And then thereafter, in the third trimester, it begins to be at the clinical judgment of the physician, is what I would say. Well, thank you for coming. We've enjoyed it.